don't know if we need this, but I want to welcome everybody. Thanks for coming. I'm Jeff Bogart. I am the Chair of Radiation Oncology at Upstate, and we've had an office in Oswego, between Fulton and Oswego at Seneca Hill since 1998, and I've been up there working since 1998 as well. We have a good program for you today. Dr. Westpfal from Oswego is going to talk about lung cancer screening, and then we have a few folks that work at Upstate but also work in Oswego. Dr. Mix is a radiation oncologist trained at Roswell. Dr. Wallen is our thoracic surgeon who came to us from Loma Linda, and Dr. Seth, I believe, grew up in the area. Is that correct? And he is a medical oncologist, but we'll start off with Dr. Westphal's talk.
Hello, I'm Dr. Westpfal. I want to let everyone know about the low-dose screening, lung cancer screening we offer at Oswego Health. So, Oswego Health is accredited by the American College of Radiology, and we are a designated lung cancer screening center, which means we follow all the standards and regulations set forth by the American College of Radiology to provide lung cancer screening with very low-dose techniques for the patients. So, who should receive lung cancer screening? High-risk patients are between the ages of 55 to 80, and they are current smokers or they are former smokers quitting in the past 15 years. These people also should have a 30-pack year smoking history. And a pack year is a pack a day times the number of years you smoke. So if you smoke 1 pack a day for 30 years, that's going to be a 30-pack year smoking history, and then that would qualify you for low-dose screening technique. If you fall within this category, you should contact your general clinician and talk to them about low-dose lung cancer screening, and they will provide you with a written order which you can bring to Oswego Health. We have 3 locations with low-dose CT scanners, one at Oswego Hospital, one at the Fulton Medical Center, and one at Central Square. Each of these 3 locations has had a new low-dose CT scanner installed within the past year. Oswego Hospital was March of 2016, Fulton Medical Center was April 2016, and Central Square was February 2016. All of these are Siemens scanners that use the latest technology called iterative reconstruction. That's a fancy way for saying that a high-power computer can reconstruct all the pixels and images using even less radiation, actually as low as 1/4 the dose from a regular CT scan of your chest. So when a patient makes an appointment at one of these centers, they come in, and this is the standard screening form that they're going to fill out to make sure that they qualify for the low-dose technique. It has very basic demographic information, and it has information about their current smoking, former smoking, and health information. This is an image, not from our system, but just a characteristic image of what we're looking for on low-dose CT scans, and what we're looking for are pulmonary nodules. So a pulmonary nodule of less than 6 millimeters has a very low likelihood of becoming cancer. So based on the size of the nodule, there are categories created by the ACR to recommend what sort of screening you need in additional. So if you have no pulmonary nodules, that would be a category 1. And if you're still a high-risk patient, they recommend continued annual screening every year. If you are category 2, which means your nodule is less than 6 millimeters, then they recommend every 12 months as well. When the nodules start getting bigger, you have slightly increased risk of developing lung cancer. So the bigger it gets, the more frequently you're going to be screened. So when you fall into a category 3, which would be between 6 to 8 millimeters, you would now go back for screening every 6 months to make sure it's not getting any bigger. And then the larger it gets, the more imaging you require because the higher likelihood of lung cancer. So we could do other diagnostic imaging for larger nodules, such as PET CT, which uses special tracers that lights up for cancer. And you can also undergo tissue biopsying, where you stick a needle in the nodule and take a sample of that. And then my colleagues will discuss those options further. Does anybody have any questions?
Just a question, would something this small show up an x-ray or not?
No, x-rays are not very reliable to actually show the nodules. You can sometimes see them, but it's very difficult. So it's recommended to do a low dose. And the benefit of a low dose is it uses a lot less radiation. And because you're worried about the lung nodule itself, you can use a lot less because the lungs don't have a lot of tissue to go through, so you're able to focus in on just that area. And the images that we scan and construct from are 0.6 millimeters thick. So we take very, very thin sections and then we can reconstruct them in many different constructs to get better imaging of that. Any other questions?
Well, how large does it have to get them before they decide that it needs?
Well, based on the lung RADS criteria, they recommend when it gets so the highest risk is 1.5 centimeters, so 15 millimeters. So that would then spark you to do additional imaging, which would be the PET CT, where you actually introduce a radio tracer, a little bit of radioactive material that's attached to sugar, and cancers metabolize faster than normal cells, so we can actually see that light up because the cancer's eating that sugar faster. So that's more helpful in a diagnosis. And then that will then spark the clinicians to do a biopsy or to do the techniques that they have available.
So when they discover a nodule, how do they know? They probably don't know if it's cancer.
Right, so you don't know if it's cancer or not. It's all based on the size. So if it's 6 millimeters or less, it's very likely that it's not it has very low potential to become cancer. Multiple people, I've seen pulmonary nodules in 18-year-olds, but the risk for developing lung cancer is age and smoking. So the older you get, your risk of developing lung cancer increases, and the more you smoke, the risk of you developing lung cancer increases.
Are there other causes outside of smoking?
There are, genetics plays a role. There are other environmental factors such as radon, which can increase your risk of lung cancer. So yes, but the highest likelihood is with smoking. Yes?
If you've never smoked, what are your chances of recovery from lung cancer? If you have lung cancer and you've never smoked? It was probably caused from environmental, mold and stuff.
I'll let my colleagues discuss that further, but the best likelihood of recovery is catching it at the earliest stage. So the smaller the cancer is, the better chance of cure and not coming back you'll have. Yes?
There are many lung nodules that are non-cancerous. Is there a way to determine through PET scan whether this is a benign nodule?
There are a lot of lung nodules can be infectious in origin, and the best indicator for that is your body responds to infection by calcifying and making it hard and just kind of blocking it off. So on a CT scan, if you see calcification within the nodule, it's going to be a 99% benign finding. So that's very reassuring. And then stability is also very reassuring. So not doing a low-dose CT, saying you don't have increased risk, we follow a nodule for 2 years to make sure it's not getting any bigger, and then we're pretty confident based on studies that it's going to be a benign process.
If it's a low dose CT that you're doing, is that in and of itself risky?
No, the low dose is, because you're already in a risky population because of age and smoking history, the risk of increasing cancer is very small because of the low dose technique. So the benefits of that minuscule increased risk outweigh the benefits of not looking for it because you already have such a higher risk of developing cancer.
If you have stage 4 and you're doing a pill, what's the advantage of doing a pill, a radiation pill, rather than something else?
I will have you save that question for my colleagues, for the oncologists.
Okay.
Thank you.
And Dr. Seth, one of our medical oncologists, will talk a little bit later about stage 4 disease and other types of treatment. I did want to introduce